Okay. So, alrighty guys. This is a very interactive session. I was instructed by Santosh. First of all, thank you to the organizers to invite me. I'm super excited to be here. I'm always been interested in teaching residents and postgraduates. I've done this for almost 20 years in the United States, and to the extent possible, what I want to do for the rest of my life is to come over here and be part of your education. Okay. What I want to do is this. I want you guys to, I'm going to show you a picture. I'm going to ask you a bunch of questions, and you have to answer. The whole bunch of questions and answers that are there based on a picture that I'm going to show. If you guys don't respond, we'll be stuck in that level. I won't be able to finish what I have to show to you in the next half an hour. Okay? So what I would like for the first years to stand up against this mic. A few of you volunteers to go ahead and stand against the mic. Okay? Each one will get a turn. Don't be scared. Okay? We make mistakes. You learn from mistakes. I did it. He did it. Everyone does it. So be bold. I do the same thing to my residents. You got to be interactive. Otherwise, this session is not going to fly. Okay? Go ahead. Just line up in all of you. I mean, a few volunteers just line up against that podium. Oh, what do I do? Okay, next. Okay. So state your name. State your name and
hello.
Where you're from.
I am Dr. Isha from Indore, MGM Medical College.
Already, Isha, you got the first one. What is common between these two?
Both have, one have very short statures, and there is stature abnormality between the two. One is short stature with stubby fingers, and the other one is a tall stature, tall limbs. So one is marfanoid and other could be Ehlers-Danlos.
Could be. So who is more likely to present with acute glaucoma between the two?
The marfanoid aperture.
What is the mechanism of glaucoma in these patients?
The scleral support is deficient in these patients for the neuroretinal rim. So there would be like acute changes in the RNFL at the disc.
So Ehlers-Danlos syndrome usually doesn't have a short stature, right?
Yeah.
So these are contrasting pictures. Both are my patients, okay, by the way. One is super tall and thin. That's Marfan's. Yeah. So the opposite of Marfan's, short stature.
Achondroplasia or dwarfism or homocystinuria. Or
Weilmarch-Sani syndrome?
Yeah,
Weilmarch-Sani syndrome, right? Yeah. Okay, so how do you manage if this patient presents to you with acute glaucoma? What do you want to do? Suddenly the patient presents with painful eye, pressure 60, eye is red hot, steamy cornea. Do you want to use pilocarpine? Do you want to use cyclogel? Do you want to do something else?
No, I would use IOP lowering agents, not pilocarpine, because these would be open angle glaucomas. They'll have large eyeballs in case of Marfan's. And
what is the basic mechanism why they're developing acute glaucoma? Why should they develop acute glaucoma if the eye is big?
Any lens subluxation or
yes, lens-induced glaucoma, right? Glaucoma. So as part of the treatment, we'd use cyclogel or pilocarpine is what I said. So the first patient, the short patient, was Weilmarch-Sani syndrome. The tall guy is, of course, Marfan syndrome. Microspheraphakia with pupillary block is what you see in Weilmarch-Sani syndrome. That's how they present to you with acute glaucomas, or more likely to present to you with acute glaucomas, right? Typically, Marfans are associated with open-angle glaucoma, less likely to present with acute glaucoma, but they can have subluxated lens, and they can also present with acute glaucoma, but less common compared to Weilmarch-Sani syndrome. Okay, so acute glaucoma is from pupillary block with lens blocking the pupil. So what you want to do is to dilate the pupil with cyclogel. The classic teaching for acute glaucoma in a typical hyperopic eye is what? Use pilocarpine. Yeah. Here, you want to do cyclogel. And the logic behind it is what you understood, right? Okay,
Yeah,
good.
because they are open angle.
Right.
Thank you.
Already, Isha, you did well. So,
Thank you.
who are you? Guys, I want you to line up. Otherwise, this session is not going to go. Make a mistake. That's how we learn. So be bold. You in the blue shirt, I want you to stand right there. Over there. I want you, yeah, there's another blue shirt there. So go stand against the microphone. And the lady with the bob cut, go against the microphone, ma'am. Listen, this is a learning session, okay? I learn from you, you learn from me. And unless you guys volunteer and shed your fears, there's no learning involved. Okay, what's your name?
Dr. Komal from
Komal.
MJ Medical.
Already, Komal. What do you got here? What underlying condition can this 3-year-old have? Hint, he is 16 diopters myope.
Ophthalmus.
Ophthalmus would be, yeah, okay. It's a good guess, but you can see what I'm trying to show there, right? I'm showing you a slit picture of the anterior chamber. Is it
Deep anterior.
No, it's not deep. You can see the gap between the iris and the cornea slit is extremely narrow. And you can get that sense even in the other picture too. It's a very shallow chamber. So this guy has a very shallow chamber, is a -16 diopter myope. What do you think is happening here?
Spherophakia.
Microspherophakia, right. So when you dilate this pupil, you can see the lens is smaller than the dilated pupil, right? So this kid has a microspherophakia, is congenital in nature. It could be associated with Marfan's or Wilmar-Shasani syndrome. Cycloplegic agents deepen the AC and relieve the attack should they develop an acute attack of glaucoma. Pilocarpine makes the AC shallow and makes it worse. I'm just re-emphasizing the fact that treatment varies depending upon the underlying condition. If you do not understand the mechanism of glaucoma, you don't know how to treat it. Glaucoma is not one disease process. Multiple etiologies make up glaucoma, the end result of all of which is elevated IOP, but the treatment varies from patient to patient, eye to eye. Okay? Alrighty. Now let's go to the gentleman over there. What's your name?
Myself, Dr. Jayant.
Sorry?
Dr. Jayant. Jayant.
Jayant, okay. Jayant, inferior fornix of a glaucoma patient and topical medication. See this picture? You got a good look?
Yes, sir.
Okay? So, question, is this patient being treated in 1960 to 70, 80 to 2000, or 2002 to 2010? When do you think this patient with this pigmentation is likely to be treated? You see this picture? What do you see there?
There's a black spot.
You got 2 dark spots, right? What do you think it is? Adrenochrome deposits. So if you think it's adrenochrome deposits, when do you think this patient got treated? 1960 to 70s, 80 to 2000, 2002 to 2010. 60s and 70s, because epinephrine as a treatment modality for glaucoma has been discontinued by 1980s because of too many systemic side effects, right? So I'm trying to get you to think through this process. Okay, his pulse is likely to be between what? 50 to 60, 70 to 80, 100 to 120. 100 and 120, because epinephrine can cause tachycardia, right? If this patient is aphakic and presents to your office with decreased vision 6 weeks after starting the medication, what is the possible reason for decreased vision? CMA, cystoid macular edema, exactly correct. Name one other medication that can do the same. Prostaglandin analogs, right. Alrighty, let's go to the lady in the middle. I want other people to line up against the microphone, please. You got to take a chance, otherwise this session is not going to work. I don't need to keep pointing fingers. Yes, please volunteer. As soon as the microphone becomes empty, I want someone else to go stand against it. Yes, ma'am. What's your name?
I'm Dr. Anamika.
Anamika, already. Anamika means?
No name, nameless.
No, nameless, right? That's what I was going to say. What is common between these two? Both are my patients, by the way. Almost everyone you're going to see are all patients of mine. I took their permission to photograph their pictures so I can share the knowledge with you, what I learned from them. Okay?
I can see a bit of a periorbital swelling, and the color of the iris is little...
Don't overread the colors. I want you to look at the facial makeup. What do you see? What kind of eyes are they? Deep set eyes, bulgy eyes?
Deep set eyes. The left eye, no, both are bulgy eyes.
These are small, deep set eyes.
The left one is small and deep set. The right one,
I don't know if I'm... Okay, so I got bulgy eyes. Okay? Now, when you see, the reason why I'm making a point of pointing this out is this. When you see someone with this kind of deep set eyes and they have glaucoma, you got to be careful. If they present to you with cataracts, you don't want to jump in and do cataract surgery. You might end up with a lot of problems. These kind of eyes with deep set eyes, what do you think is the diagnosis for these patients?
non-ophthalmos can be
So what kind of glaucoma are these two likely to develop?
angle closure glaucoma.
Chronic angle closure glaucoma, and sometimes an acute attack can pile up on top of the chronic angle closure glaucoma, right? Yes. So if the first patient presents to you with IOP of 36 on maximum medical therapy in a phakic eye, you do a trabeculectomy. 2 weeks later, the AC remains shallow with IOP at 26. What is the next step in the management? What year are you in? What year postgraduate are you?
So I just finished my second year.
You finished your second year, so you must have finished your glaucoma rotation?
Yes, sir.
Yes, sir? Yes? Okay, good. Now, if you do a trabeculectomy operation, okay, and a couple of weeks later the patient presents to you with increasing intraocular pressure and the AC is shallow, but the blood is formed, what is the likely diagnosis? Anyone?
Choroidal effusion.
Huh?
Choroidal effusion, suprachoroidal effusion.
If there are choroidal effusions, the pressure is what usually? Low. Here is 26. Could be malignant glaucoma. That's right. Now, how do you differentiate? What other condition can present with shallow chamber, high IOP in a post-trabeculectomy? Pupillary block glaucoma, okay. What else? Suprachoroidal hemorrhage, right? That also, but in suprachoroidal hemorrhage, there's severe pain, right? So that's how you know, even without doing any imaging studies, you can always listen to the story of the patient and you have a few physical findings, you can always deduct as to what is happening. Glaucoma is a thinking disease process, okay? It's not just taking out cataracts. I do a lot of cataracts too, by the way, refractive surgeries too, but glaucoma is a very challenging disease process. I'm trying to encourage you to take up glaucoma because 6% of Indians have glaucoma and we have only 100 glaucoma specialists. That's not good. 6% out of a billion population is a lot of glaucoma patients floating around this nation, and we need trained, comprehensive and glaucoma specialists, anterior segment specialists to take care of this population, okay? And it's a very challenging field. It's very intense when you take care of these glaucoma patients because you're trying to prevent them from going blind. But when the patient presents to you, even though the end result is elevated IOP, like I said, every single patient presents to you in a different fashion, and you got to think through this process. So this patient, more than likely, like somebody pointed out, is in the process of developing malignant glaucoma. When you operate on someone with shallow chambers and do a trabeculectomy, there is a higher likelihood for you to develop malignant glaucoma, okay? So if you want to avoid malignant glaucoma in these patients, the way to treat these patients is to take
We can give mediatrics. We can give mediatrics, we can give atropine.
That is after the attack is happening. But if you want to prevent it from happening at all, you want to redo that anatomy and make it more towards normal size, right? What is the basic pathology in normal nanophthalmos? The eyeball is small, right? 18 millimeters or smaller than that. But the underlying lens is the same size as you and me. So there is a big lens related to the small eyeball. So what you want to do is to take the damn lens out. Take the lens out. Then the anterior chamber is going to fall open. At that point, do a goniosyncytial, open up the angle, and more than likely, you will prevent this patient from going blind from glaucoma in the long term. I've done that on several nanophthalmic patients over the years. They're all doing great. The trouble starts when you do not recreate the anatomy and you blindly do a trabeculectomy operation on these patients. You will end up with problems, malignant glaucoma and such and so forth, and then you end up in more trouble than what the patient came to you with. Okay, so every time, anytime you see these patients with deep set eyes, think twice, okay? Think about nanophthalmos, think about the hyperopic, high hyperopia, and the likelihood of these patients developing angle closure glaucoma. Okay, alrighty, what's your name?
I'm
Thank you.
Dr. Vishwendra from Tirunelveli.
Vishwendra?
From Tirunelveli.
Tirunelveli. Vishwendra, yes. What do you think is wrong with this lady? You got to make it fast. I need someone else to fill these microphones, please. Somebody else volunteer, go stand against the microphone in the middle row. Do you want help? Okay, call one of your friends. Throw a helpline. Call one of your friends.
There is dystopia, sir, in the left eye.
Left eye is riding low compared to the right eye, right?
Yes, sir. Yes,
And what else is happening here? You can see there's something going on here. So what test do you want to order? If I give you a choice, what do you want to order for this test, for this patient? Call your helper to the microphone. Come on. Guys, if you do not participate in this in an interactive fashion, this kind of a session is not going to be helpful, neither to me nor for the rest of the crowd. Who wants to order a test on this patient, and what kind?
Need to examine the orbit.
Okay, so you want to order a CT scan, right? So here is a CT. On the left side, you can see the bone is thickened, and the optic nerve area is compromised, right? That's what is pushing the eyeball down. So what do you think is the diagnosis? So based on this attached picture and that CT scan, what is false in those statements? A, this patient is likely to experience persistent bilateral hypotony on exposure to acetazolamide, which is Diamox. B, this patient should use protective goggles. C, this patient can experience sudden loss of vision. D, this patient can experience gradual loss of vision. What do you think is the correct answer? Anyone? What is wrong with this patient, by the way? What do you think is wrong with the patient? Isha? Huh? Right. But what is the disease process, underlying disease process? I gave you lots of hints here. Protective goggles, sudden loss of vision, gradual loss of vision in a patient with bone thickening. Right, but what is the underlying disease process? What is the name of the disease that I'm trying to highlight here? Anyone? Paget's disease, right? Yes? Paget's presents exactly like that. Okay, so in Paget's disease, what is the ocular condition that is associated with them? Angioid streaks. So when you have angioid streaks, there's the cracks in the Brooks membrane. So if this patient undergoes trauma to the eye, they can develop new vessels to grow through those cracks, and they can potentially lose their vision. That's why they're supposed to wear protective goggles. Now they can, the bone can compromise, increase in size and narrow down the optic canal, compressing the optic nerve. So there's a gradual loss of vision. Because of the bleeding from those choroidal blood vessels, new vessels, they can have a sudden loss of vision, right? So the answer is A, but I want to know this condition is true in which disease process. Patient is likely to experience persistent bilateral hypotony on exposure to acetazolamide. There is a condition that if you give acetazolamide to that patient orally, he or she might end up with bilateral low pressures. Anyone knows what condition I'm talking about? Sickle cell disease. When you give somebody acetazolamide, it's going to make the fluid more acidic. That means the blood RBCs are more likely to sickle. Sickling causes blockage of circulation to the ciliary processes, and it can actually cause the ciliary processes to die down from lack of circulation, resulting in bilateral hypotony. So in sickle cell glaucoma, you should avoid giving them Diamox, acetazolamide. Okay, got it? Alrighty, let's go to the next question. 31-year-old, I'm too young to be losing my vision. He's African American. African Americans are more likely to develop glaucoma, as you may well know. Advanced glaucoma on Combigan, that's the history with which he came. Pathologic myopia, -18 to -20 diopters. So those are his optic nerves. We just heard a lecture on the appearance of the optic nerves. Intraocular pressure was 23 in both eyes. CCT was 528 in both eyes. Vision 20/100 and 20/40. Have a good look at those optic nerves. Do they look glaucomatous optic nerves? Do they look like myopic optic nerves, or there's some other pathology going on here?
It looks like a glaucomatous optic disc. The cup disc ratio is increased and there is a pallor of the neuroretinal rim with tessellated fundus.
So there is large cupping, but there's a pallor also in this patient, right?
Yes.
Pallor is out of proportion. Do you see a lot of pallor in glaucoma patients?
No, sir.
Generally, no. You see large cupping, yes. Thinning rim, yes. But pallor is not something that is common in glaucoma patients, right? So here are his vision fields. What do you see?
Ring scotum, arcuate and...
This diffuse loss of the vision field, right? The generalized loss, with some areas that are denser than the others. And you can see that the
loss
OCT,
of nerve fiber layer.
right, retinal fiber layer is almost flat. So what further investigations do you want to do? Do you want to do anything else before you start treatment based on the optic nerve appearance and the vision fields and the loss of vision?
B scan.
To find out what? What is the B scan likely to show?
Any posterior staphyloma.
It doesn't interest me. What you want to think about is this pallor pathologic? Is there something else going on other than glaucoma in this patient? He's 31 years old. He came to you telling me...
Cardiology workup.
Cardiology workup.
For,
Will cardiology give you pallor?
For atherosclerosis of the
In a 31-year-old?
MRI.
MRI. Okay, you want to make sure that there is no tumor in the brain. Okay? So this patient had a workup for optic atrophy, okay, because he's got pale nerves that happen to be cupped too. So you got an MRI of the brain, and then the blood tests were all normal. MRI showed symmetric bilateral optic nerve atrophy and atrophy of the chiasm. And I did a CDL tonometry after adding glaucoma medications, some more glaucoma medications, and the peak pressure was 20. The lowest pressure on CDL tonometry was 11. So does that MRI reading report suggest anything to you? Is this glaucoma or is this something else? You can ask for a helpline. Call someone else. Call one of your friends. You don't have a friend here? Okay. Yeah, there you go.
Sir, atrophy of chiasma can be due to pituitary tumors.
But there is no, did they talk about pituitary tumor there? The report didn't say there is a pituitary tumor. But can you see optic chiasm atrophy in glaucoma patients? Yes or no?
No, sir.
No? So in glaucoma, what happens? The ganglion cells are lost, right? Right?
Yes, sir.
So from the ganglion cells, the axons come out,
Right.
and the axons go and attach themselves to where?
Goes to the cortex, means via optic nerve pathway.
Yeah, but the first stop is where? They
Optic
cross
tra-
over in the chiasm and then go to
Lateral geniculate.
lateral geniculate body.
Yes.
So in glaucoma, if you do histology of the brain, in patients with advanced glaucomas, the nerve fibers axon, number of axons die down. Don't you think the chiasm thickness also goes down?
Right, sir.
Yes, that's all they're trying to point out. All I'm trying to point out is you need to correlate and don't jump to conclusions. If you think through the process of the disease, then you know you should be expecting thinning of the chiasm in patients with advanced glaucoma. Okay, what they're showing there is nothing more than what you normally expect in patients with glaucoma. That's not a disease process of the neurological disease process. Okay, so the target pressure in this patient, because now he has advanced glaucoma, right? So what is the target pressure that you want to shoot for? Low.
Sir, around 10 to 12.
10 to 12. So what is the surgical intervention that you want to propose for this patient?
Sir, trabeculectomy.
Trabeculectomy. So if you want to do trabeculectomy, what do you want to avoid in the middle of trabeculectomy, given his history?
Sir, mitomycin C.
You want to avoid mitomycin C because there's an increased risk of?
Scleral thinning and can lead to perforation of the sclera due
Nah, there's an increased risk of hypotony maculopathy in patients with myopia if you use mitomycin C. Okay? That's why you want to avoid using mitomycin C in these patients. Okay, I don't see any volunteers coming up here. There you go. What's your name, ma'am?
Danya.
Thank you. You guys can sit down. I want new
Thank
people
you,
to
sir.
come up against the microphone there. Danya.
No, I'm comfortable, sir.
Danya?
Yes, sir.
Alrighty. Where are you from?
Madurai.
From Madurai. Yesterday I was in Madurai. Day before yesterday, and yesterday I was spent 2 days, 2 nights in Madurai, and I went to Meenakshi temple, and yesterday morning I was at Aravind. Fabulous place. So 55-year-old white male referred for glaucoma evaluation. Vision is 20/50 OU. Intraocular pressures are 18 in both eyes. CCT is 530. Open angles. Here are the optic nerves. What do you see?
Normal size disc with inferior rim sloping in both eyes.
Uh-huh. What else? What-
Enlarged.
What's the
Enlarged.
most striking feature of those optic nerve heads?
Cup disc ratio is around 0.7 with temporal pallor.
Pallor is the most striking feature of these optic nerves, right? There's not much cupping that you see there. You see the optic nerves are pale, both eyes, right? Compared to the previous case where you can see deep cupping with the loss of rim, in this patient, the most striking feature is pallor. So, what do you think is the diagnosis? Is this glaucoma?
Neurological cause.
Could be. So, what one test you want to order that is not expensive sitting in your clinic? You're in Madurai in your clinic. What test do you want to order?
Color vision and central fields.
Color vision and the vision field. Here is the vision field.
Starting inferotemporally could be a craniopharyngioma.
Well, how do you say this? How do you read this vision field?
It's got bitemporal hemianopia
Bitemporal hemianopia, you're right. So what is the differential for bitemporal hemianopia?
Optic chiasma lesions.
Chiasmal lesion. So this patient more than likely has a pituitary tumor, so you want to do an MRI. So not all optic nerves that look a little different have glaucoma. Every year I get to diagnose at least 1 or 2 pituitary tumors that present to us that have been treated by general ophthalmologists as glaucoma for a few years before they send the patient to me, and then for surgery because they're progressively losing their vision. So looking at your optic nerve should become part and parcel of your everyday life. Okay? Every single patient that comes through you to your clinic for the rest of your lifetime, you have to look at their optic nerves. Don't be one of those doctors who give glasses or just take the cataract out and don't want to know about the rest of the health of the patient. You're doing the patients a big disservice. Every single patient deserves a full eye exam when the patient presents to you in the clinic. Okay? Got it? Okay, we're running out of time, but I want a postgraduate third year student to stand up. Thank you. Who has done several trabeculectomies? Yes, ma'am. You in the black. Black dress, that's you. Yes. The two. Okay, well, yeah, there you go. What's your name?
Sir, Rumi Das.
Huh?
Rumi, sir. Rumi.
Umid?
R-U-M-I.
Oh, Rumi. Okay, already. So here is a patient that presented to me. She had trabeculectomy operation done somewhere else. She was not happy. She said, ever since the operation was done, I think I lost my vision. There's something wrong with my vision. She was not happy. So she came to me for a second opinion. So she, with disturbed vision following trabeculectomy operation, what do you see?
Sir,
We're running out of time here.
it's a blemish in, but there is
Huh?
sir, it may be bleb failure.
You see a bleb here,
Yes.
right?
Yes, sir.
And but what happens to the lid? When compared to the other eye, when compared to the right eye, the lid in this eye is?
So it's retracted.
It's retracted. So there's lid retraction with exposure of the bleb, right?
Yes.
So here is up gaze. What do you see? When the patient is trying to look up, left eye is not moving up.
Yes, sir.
So here is in the primary up and horizontal gaze, okay? So most likely reason for disturbed vision in this particular patient is A, astigmatism from trabeculectomy, B, cataract formation secondary to trabeculectomy, C, superior branch of the third cranial palsy, D, the choroidal effusion. What do you think is happening with this patient?
Sir,
Anyone? Huh? Astigmatism. But how does that explain the situation that the patient has a retracted upper lid and is not able to look up?
third nerve pulse.
Huh?
Third nerve pulse.
Third, why do you think she developed third nerve palsy following trabeculectomy operation?
Superior rectus during
During what?
during giving bridal suture.
Bridal suture or through the superior rectus? Is there any other reason why the superior rectus muscle could be disturbed? It's not only the superior rectus muscle.
LPS.
It's the lid is also retracted, right? What muscle in the lid is affected there?
LPS.
LPS. So you have both the LPS and the superior rectus muscle that are affected in this patient in the process of doing trabeculectomy. So what one reason why both the muscles are affected or could be affected? Anyone? Local anesthesia, retrobulbar injection. So when this lady got retrobulbar injection, they injected into the area of the third cranial nerve branch. The same branch supplies to the LPS and the superior rectus muscle. And that branch got affected, resulting in what you see there. Right? I got to quit here simply because I'm running over the glaucoma surgery sites. But anyway, I mean, they're like, I do this for my residents all the time. Make note of my email address. See, that's why I said it's interactive. If you guys don't answer the questions, we'll be stuck at question number 1, okay? And you'll never go to the last question. I want to show you some of the surgeries that we do for glaucoma. What I do is this. I do a lot of online teaching, okay? Those of you who are interested, can someone show the last slide here? Okay, there. That's my email address, okay? rsayyala@gmail.com. Send me emails, and next time when I run these courses, they're all online. It's pretty simple for you to follow these courses that I run. You can find me on YouTube. You can find me on my website, Meditread, and I'll be more than happy to share with this. A lot of residents in the United States follow me when I do these lectures, not only for my residency program, but several other programs in the country there. So I want all of you to join me so we can, it's a nice interactive medium, and it's going to be early in the morning for you, night for us, and that way I also run the Ananda Institute in Hyderabad. My residents from there also are recently joined me in my lecture series, so we can go through various aspects of glaucoma, okay? Can I have the next? I want to show you how I do glaucoma surgeries. Glaucoma surgery is not just a trabeculectomy operation, okay? Glaucoma, like I tried to tell you, is a disease process. Where is it? Okay, glaucoma surgery is a disease process that has multiple etiologies, and the end result is elevated intraocular pressure and optic nerve damage, consequently blindness. So when you take care of these patients with glaucoma, it's irreversible loss of vision that you're talking about. You're talking about a 40-year-old or a 60-year-old going blind permanently. You know what happens when a bomber out there in Madurai is going blind? It means the same thing as going blind from cataract, except in cataract, you take the cataract out, the vision is back. Whereas in glaucoma, there's no coming back because we, the scientists, have not discovered how to regenerate the optic nerve. Till such point, the cure for glaucoma is in controlling the intraocular pressure. And you can limit the rate at which they lose their vision as time goes on, but you cannot recreate the vision that's lost from glaucoma. So for any disease process, any surgery that you want to look, whether you do cataract or refractive surgery, cornea surgery, or glaucoma surgery, you want to know the anatomy, you want to know the pathology. Very important for you, patient selection, surgery technique. What I'm going to show you is edited versions of surgery because there is lack of time, step by step with pictures following by the video, intraoperative complications and management. If you want to do any kind of surgery, I don't care what you want to do, cataract or glaucoma, every one of us will have complications. There's no surgeon on the planet who can stand up and say, I don't have complications. They're lying to you, okay? Take it from me. I've done thousands of surgeries for years on end. There's only one response when somebody tells you, I never have complications. They're not either doing enough surgeries or they're lying plain to you, okay? All of us have complications. The good surgeon is differentiated from a bad surgeon by one thing: acknowledging, recognizing the complication, taking care of the complication. You don't want to throw the patient on the street and say, I'm so sorry, but this is all it is. You should know how to manage your complications. When you create it, you manage it. You don't refer these patients out. Train yourself to the point that you become the specialist and the guru in this technology, in that field, okay? So, I mean, managing the intraoperative complications, managing the postoperative complications is extremely important. Now, anything that presents to you, I want you guys to start thinking differently. When a patient with acute angle closure glaucoma presents to you, what do? The state of the art is what, Isha? When a patient presents to you with classic acute angle closure glaucoma, pressure is 60, the patient is throwing up, right? The eye is steamy hot, and the corneal edema, vision is count fingers. What's the first thing that you do? Huh? Right. Yeah.
We use systemic IOP lowering agents like mannitol or glycerol so that IOP drops
How long
down
does it take for the mannitol to kick in?
For 10 to 15 minutes.
Okay, and then what happens?
And then we, if the IOP is low enough, we shift the patient to oral acetazolamide and we start topical IOP lowering agents as well.
So this entire process took about a half a day of the patient's lifetime and your lifetime, right? I'll show you, right? Yes or no? In the meantime, the patient is throwing up and you're checking the pressure every 10 minutes. You're dropping the pilocarpine and the betamol or whatever else drops that you have. I'll show you a simple technique. Here is a patient. He's an oil merchant. His cousin happens to be an ophthalmologist. He's a minor +13 hyperope. She dilates him, puts him into an acute angle closure glaucoma attack, and so the patient, after 4 days of throwing up continuously, was referred to me. All I'm doing there is to take a 30-gauge needle. You see the needle there? 30-gauge needle at the slit lamp. The minute I saw the patient, I put some betadine, some topical anesthetic, lid speculum, put the patient against the slit lamp, a 30-gauge needle, and you stick the needle into the anterior chamber. Okay? Stick the needle into the anterior chamber, and you wait for less than a minute. All it takes is to get 1 or 2 drops of aqueous out of the eye through that needle hub, and the pressure drops down, pain is gone, cornea gets clear, and you're done. The attack is broken. At that point in time, you take the patient to do a peripheral laser iridoplasty, and you can do a YAG PI if you want, and then a week later, take the lens out, because the underlying pathology there is, again, the same thing as non-ophthalmos, right? The lens is too big for that particular eye, the way the eye is structured. So cure the basic problem, which is to take the lens out. So schedule the patient for cataract surgery, and you're done. This patient is never going to have this attack again. You don't need to follow this patient ever again. This is one disease in glaucoma, of all kinds of glaucoma that you have. This is one instance where you can offer definitive cure and tell the patient confidently, you don't need to see me ever again. Yes? In 5 minutes, you're done taking care of this patient. There's no mannitol, there's no Diamox, none of those drops that you worry about. In 5 minutes, the patient is happy and healthy, and you schedule them for a regular cataract, and you're done. Think differently. Every time you see these patients, this is where innovation happens. I want all of you to start questioning, not in an arrogant fashion. Don't question your professors in an arrogant fashion. They are practicing medicine as they learned it at their point in time of their lifetime, right? You guys are young, you guys are techie. You grew up in a Google age. Your knowledge base is much wider than ours. So use your new knowledge that you have acquired in your lifetime to better the human conditions, okay? So know your anatomy when you do this disease process. Aqueous outflow, you know that, right? Ciliary processes, aqueous goes into the anterior chamber, trabecular meshwork, Schlem's canal, and the collector channels. We know this pathway. So in glaucoma, where is the major site of resistance? Juxtacanalicular area, right? That's why the aqueous is held back. So you want to crack this puzzle of high pressure. What you want to do is an enlarged view, gonio view of the same, and here is the surgical limbus. It's extremely important for you to know the surgical limbus. Here is the sclera, here is the cornea, this is the corneoscleral junction, this is what we call as the surgical limbus, right? So here, underneath the sclerolimbal junction and the corneal limbal junction is where the Schlem's canal lies. Almost every single time when you make your trabeculectomy flap, look under. You will find the Schlem's canal. There's no way you can miss it. There are some instances you might, but you start looking at it, you will start recognizing it. And that's how the canaloplasty procedure was born, and the rest is history. Okay, so the changing phase of glaucoma surgery, design surgery is based on anatomy and underlying pathology, right? So the standard of care for a long time, for the last 30 years, 40 years, has been diversion of aqueous humor into subconjunctival space. That is bleb-dependent surgeries. So the key learning point with these bleb-dependent surgeries is that they achieve the maximum intraocular pressure reduction and possibly the maximum complications too. Once you create an artificial bleb on the conjunctiva, the bleb can get thin, it can leaky, it can become leaky, it can get infected, the bleb can stand out like a stone, foreign body sensation, all these problems can happen. But guess what? A beautifully created bleb can last a long time and can save this patient's eyes from going blind. The examples of this are trabeculectomy and glaucoma drainage devices. So the way I do this is a completely edited version. It takes me 15 minutes. How do I know this? I've done thousands of these procedures. Every time you do a surgical procedure, you got to divide that into steps mentally and then decide how you can make it better and more efficient. And time yourself. And that's how you're like a cricket player, right? I can score this many runs in this much time. The same thing, a super surgeon, well, what they do is you want to time yourself. You want to say, what can I do to make this particular step better so the next patient will benefit from this? Every single eye that I have done, I always question myself. That's how you become more efficient. So the surgery is all over, right? I mean, let me play this for the sake. So this is under topical anesthesia, lidocanopy mixture that I give. Balloons the conjunctiva, gives the anesthesia. Dissection is easier. I raise the flap. I'm wiping my mitomycin-soaked Vexel sponge. Now, here is the key. The cut that I'm making is not at the level of the sclera. You cut into the sclera with a punch, what happens is it tends to bleed because all the blood vessels are there. You want to do an avascular surgery that doesn't bleed. So the cut is into cornea. So this is not a trabeculectomy per se. I'm not cutting the trabecular meshwork, which is what they believed in the past. Rather, what we're doing here is to create a cornea valve. And that cornea valve will function by regulating the pressure in a, it's not 100% foolproof, but it's better than the old-fashioned surgery of trabeculectomy, okay? So here is the posterior placement of mitomycin. Here is how you can see that I dissected the flap into the clay cornea by approximately 0.2 millimeters, and then making entry, and then punch, and you can see the punch. You see where the punch ended? That's the sclerotomy or the corneal hole that I created. It's in clay cornea, just adjacent to the limbus. And then, of course, you close it, and there's a nice diffuse bleb. And you notice I did not lose a chamber right through the procedure, right? It's a trabeculectomy, when well done, is a beautiful thing to watch, and is a beautiful thing to perform. A lot of people do not know how to do a good trabeculectomy. That's why you end up with lots of complications in the middle of surgery and post-op. So know your complications. So I'm going to show you a couple of examples of complications. All of us are familiar with this avascular cystic, huge, humongous blebs that stick under the upper lid, and they become they cause a lot of discomfort for the patient. The patient complains of foreign body sensation all the time, or sometimes they become leaky. Okay, and the pressures drop down too low. When there is a leak, what it is setting you up for what? Infection, endophthalmitis. These patients can go to bed with 20/20 vision, wake up next day morning with zero vision, NLP vision. These blood-related endophthalmitis are much more aggressive compared to cataract-related endophthalmitis. Okay, so what I'm doing here is this. I dissect out the conjunctiva using the same technique of lidocaine injection, but you have to preserve the draining vessels from the bleb, decrease the height of the bleb with cautery, a series of cautery applications to decrease the height of it, drape it with amniotic membrane, and then pull the conjunctiva down, use relaxing incisions, and then tack the conjunctiva on top of that amniotic membrane back to the limbus. Now you have a beautiful, nice bleb. And this patient is unlikely to have, I've done quite a number of these kind of patients. The beauty of this technique as compared to the other techniques that have been described is that A, you will never lose the chamber. B, more than likely, almost 80% of my patients, the intraocular pressure is maintained between 8 and 15 on one medication at the most, and the failure rate is less than 10% with this kind of surgery. The other way around, people have described this to excise that avascular cystic bleb and pull the conjunctiva from here and there, and that results in what? A lot of failure within 3 to 6 months, right? And also, you end up with more complications with that. So, suprachoroidal hemorrhage, another feared complication of glaucoma surgery. No matter how good you are, it is not your surgical technique that causes it. It is because of the pressure, because of the underlying anatomy of the eye and underlying pathology that the patient presents with, plus or minus things that he or she should not be doing in the immediate postoperative period, right? So here is a patient that was referred to me with suprachoroidal hemorrhage in the middle of doing a phacotrabeculectomy by another surgeon. He ended up with suprachoroidal hemorrhage. He referred the patient to me. You want to wait for about 7 to 10 days before you do the sclerotomy on these patients because the blood, once the blood goes into the suprachoroidal space, it tends to clot. So if you were to be the surgeon, and the suprachoroidal hemorrhage happened right then and there, you have the opportunity to do the sclerotomy right then and there on the table, and that's what I would do, strongly encourage you to do. On the table, if you're the surgeon, do the sclerotomy. If somebody sends you or the patient comes to you with the suprachoroidal hemorrhage, wait it out for 10 days, let the clot dissolve, and then you do the sclerotomy like we're doing here. Two things which are key. It's the same technique for choroidal effusion drainage too, by the way. Sclerotomy gently into that pocket while maintaining the pressure in the anterior chamber. If you don't maintain the pressure in the anterior chamber, the eye becomes too soft and it can start bleeding all over again, right? So pressurize the chamber with the AC maintainer. As you do this, you make the sclerotomy and the blood will drain out. There you go. Boom, right? Now going back to glaucoma drainage devices, let's switch gears. Patients that do not are not responsive to these trabeculectomy operations, they scar down. The next step in the evolution of treatment is to go to a glaucoma drainage device. Here is an example of the Barwalt implant. I understand in India right now you have the Orolab implant, which is based on, it's exactly the same model, by the way. So this is a non-valved implant. What you want to do is to tie the tube shut, because if you put a straight tube with no valve, no restriction to it from point A to point B, a high pressure chamber to a low pressure chamber, what's going to happen? Continuous flow, too much flow out of the eye. What will happen? Hypotony and hypotony related complications. To avoid that, what you want to do is to have a restrictive proline, 7-O-proline suture that will dissolve over a period of 4 weeks. Now in that 4-week period, you might have high pressures, right? So what do I do in those kind of eyes? I open up the previously failed trabeculectomy operation at the end of this surgery. That functions for the next 2-3 months while the Barwalt implant will take its own time to open up. A combination of both will have immediate postoperative pressure control and long-term pressure control. You got it? That's the technique. You see this? That's what I'm doing here. This is a 23 gauge butterfly needle. I'm putting it in the sulcus in this patient. In the interest of time, I'm going to speed up. Okay, so you see the tube is in there, and then I'm going to open up the trabeculectomy operation before I close the conch. You see this? I open up the trabeculectomy operation that failed from before. And now the trabeculectomy starts functioning. I leave viscoelastic in the anterior chamber, close the conjunctiva. So you have a partially working trabeculectomy operation that does the immediate postoperative control. And in about 4 to 6 weeks, the vicryl is going to dissolve, the tube is going to open up. Now, the other device that we commonly use is called the Ahmed valve. This is an example of a variation of the Ahmed valve theme. This lady has scleroderma, tight conjunctiva, pressures were like 55 millimeters of mercury on maximum medications. The lids are the deep set eyes, tight lids, scleroderma, conjunctiva is plastered down, so you could not even do a conjunctival dissection. In those cases, what do you do? What am I doing there? Partial scleral dissection to create the pocket that I want. So the first 4 millimeters are the only ones that are plastered out in these cases. You do the partial scleral dissection and then open it up into the posterior conjunctival space and then use a smaller plate Ahmed valve, and the operation works beautifully. See, once the dissection is done at that point, you want to bring the Ahmed valve. There goes the Ahmed valve. Okay, let me show. Okay. Now the Ahmed valve comes with a valve, a polypropylene plate, which is folded like your roti. Okay, chapati. So fold the chapati into half, and then stick a tube on the closed end or the folded end. That is Ahmed valve. Okay, it's nothing more fancy than that, except you have to irrigate the valve open before you place the valve in. Okay, so one thing that it does well is that it doesn't give you pressures of 0. It gives you pressures between somewhere around 8 to 10 one day post-op, and that's the beauty of that valve. Okay, let's move on to something else. Zen, I don't know if you heard about Zen. It's a new kid on the block in this arena. There are a couple of new things in terms of micro-invasive surgical procedures that are coming in to the marketplace, and Zen is one of them. This is a 40 micron, 45 micron tiny tube that you inject through the anterior chamber, rather than, so the tube goes in to drain the fluid from the anterior chamber subconjunctival space. The way it works is still scar tissue is a problem, so I'm injecting subconjunctival mitomycin there. See, I'm spreading it out. Now you make an entry into the anterior chamber, that's your paracentesis. Okay, here comes the Zen. The Zen is loaded on a needle, and what it does is this. You go through that entry into the anterior chamber. Under gonio view, you locate the Zen just anterior to the trabecular meshwork, the needle, and then you come out into the subconjunctival space about 2.5 to 3 millimeters posterior to the limbus. There. Once it's out there, you through the injector, you inject the Zen. It's going to get large into that space. About millimeter to 2 millimeters is left in the anterior chamber. 3 millimeters to 4 millimeters is left in the subconjunctival space. So the idea is that it starts draining into the subconjunctival space with minimal dissection. So unlike a trabeculectomy operation or valve, there's no conjunctival dissection per se in Zen. But you know, we started doing Zen about a year ago. The results have not been that encouraging. It works in some patients. A lot of patients, they're developing scar tissue that's blocking the tube, and consequently, I'm skeptical about the long-term use of this. Now let's move on to the Schlem's canal surgeries or mixed surgeries. Canal-based surgeries can be what? Multiple ways of increasing the flow across the canal. Like we learned, juxtacanaliclar area is where the maximum resistance is going to be. So you can remove the trabecular meshwork, open the canal straight into the anterior chamber, bypassing that area of resistance, right? You do that either with eye stent or with the trabectome or KDB, which is a Cahoot dual blade. Or you can open up you can do like a goniotomy 360 degrees using the trabectome 360 or GAT procedure, or stretch the canal using the canaloplasty procedure. I'll show you some examples. It's not possible for me to cover all of them. So here is a patient with cataract surgery, post-cataract surgery. That's the eye stent that's going in. It's a pretty straightforward procedure when you know how to do it, a steep learning curve. But remember, that's Ike Ahmed, whose brainchild that eye stent is. It's not his brainchild, but he's the one who popularized the eye stent formation. This is the Cahoot blade. What I'm doing there is to lodge it into the Schlem's canal, peeling off the trabecular meshwork, opening it up. That's Malik Cahoot from Colorado. And what people like me do is to combine eye stent with the Cahoot blades, or eye stent with ECP, or with ciliary processes destruction. So you combine two mixed procedures. You're increasing the outflow through the Schlem's canal by peeling off the trabecular meshwork or bypassing the trabecular meshwork. You're decreasing the aqueous production by applying diode laser to the ciliary processes. A combination of both appears to control a lot of these patients with mild, moderate glaucomas. Now, here is an example of this combo surgery. This patient has narrow angles and cataract and pressures of 30. What do? Instead of doing a trabeculectomy, I take the cataract out. Here is the Cahoot dual blade. I placed it into the Schlem's canal. I'm peeling off the trabecular meshwork. So all of these surgeries you have to do sit on the temporal side because of the way the anatomy of the orbit is. There's only the nasal 180 degrees that you can access, okay, when you do these surgeries. So here is and once that's done, I am introducing the ECP or endocyclophotocoagulation curved probe, and that's the ciliary processes that you're seeing there. The lighting from the camera causes that kind of a glare effect there, okay? But you see, and then you apply laser to it, it decreases the ciliary, the production of the aqueous. And once that's done, you wash out the antechamber and you have nice quiet eye. You inject some steroid into these eyes, they have a nice quiet eye, and they do very well. And the third way you can do this is to decrease the aqueous production, right? Here is an example of the ECP in a much better setting. Here is a patient with plateau iris syndrome. You must have seen patients with plateau iris, which was one variation of chronic angular closure glaucoma. I take the cataract out like I always say you should. Now, here you can watch on gonio, the angle is completely closed. You see this? This is a closed angle. So what I'm doing is to do peripheral goniosyncytialysis, introduced micro forceps, and using the micro forceps, I'm peeling the angle open. When you do that, sometimes it bleeds. It should not bother you that much because at the end of the day, you're going to wash it out. By opening up these angles, you'll be surprised that underlying trabecular meshwork Schlimm's canal is still functioning. Okay? So take the opportunity to open up these angles wherever possible after the cataract surgery, and you will have lower intraocular pressure from these patients. And once that's done, I introduce the endocyclophotocoagulation probe. I'm trying to show you, okay, here is the ciliary processes, and once the ciliary processes are affected by the diode laser, you can see the red dot is the diode laser. It turns white. That's what you want to do. Okay, turn them white, especially in the valleys, to attack the areas of the aqueous production. A combination of both of them will reduce the intraocular pressure. I think my time is out. I want to leave you with small variations of the theme that I take care of. Here is a lady who's born, here is an infant, a 1-week-old infant who was born with sclerocornea. And that was brought to me with LP vision in both eyes, bilateral sclerocornea. We didn't even know where the limbus was. I use a 6mm trephine. I do a lot of cornea work too, by the way. I do my own cornea transplants, DSECs, traps, K-pros, etc. So here is this child. So I did a corneal dissection, and you can see there's a modified Peters kind of a pathology that this child had. And I placed a new graft in, put a valve in this eye, and the child is now 3 years old. She's able to read iPhone. She holds her iPad close to her eye, and she's able to read it. She knows her number. She knows how to read. Every time she comes to the clinic, she says, "Dr. Ayyala, I want to show you something else." And she gives me a kiss, and then she walks out. They're very rewarding cases to handle. You see these babies who potentially could be blind, you give them vision, and it's a nice satisfactory feeling for you to be involved in. But for you to achieve this, you need to know you need to have these skill sets for you to have. Okay, I will finish with this last case. This is a complicated cataract referred to me by a retinal specialist after doing retinal surgery, whatever they have to do. And the patient had a phacomorphic kind of a glaucoma with pressures of 40. So I thought, and the angle was closed, I thought it's mostly phacomorphic glaucoma. So I did a cataract surgery. You can see how milky that cataract is. Put the lens in, the chamber still remained very shallow, and the pressure did not come down soon after the cataract surgery. So what do you think is happening here? So I figured it could be angle closure that is causing the chamber to stay still shallow, right? So I go in now, I try to peel open the angle using the microforceps and the blade technique. Even after that, the chamber was still shallow. What do you think is happening in this eye? We talked about this entity a little while ago. Malignant glaucoma was the underlying pathology. So this patient had 3 pathologies, all of which, each one of them could have caused the glaucoma. Okay, first was a phacomorphic glaucoma like you saw. That lens was almost touching the cornea. That's how phacomorphic it was. Took the cataract out, nothing happened. Then I went after the angle structures, nothing happened. So at the end of it, what do you think I did? I took a 30-gauge needle. 30-gauge needle for a glaucoma anterior segment person is your best friend in the clinic and in the surgery. I do a lot of procedures using 30 gauge needles. I stuck the needle through the iris and the posterior capsule, and suddenly the antechamber deepened. And so I will end.
I think we
Let's
can
just
conclude.
just one. This is a slit lamp procedure. You do your tubes and traps, and the patient ends up with flat chambers. What are you going to do? You have to take the patient back to the operating room to reform the chamber, right? Instead of that, you can do this procedure right at the slit lamp, and it works very well. A lot of this is in your own mind. You have to develop your techniques so as to help these patients out. So with that, I just wanted to show you that there's a lot more to glaucoma than doing trabeculectomy. Glaucoma is an exciting field at this point in time, and if you master all the techniques and choose the right surgery that works for that patient's eye, you will be helping out a lot of patients from going blind. Thank you. Thank you for giving this opportunity.